Okay, great. So, good morning, everyone. Just without wasting time, let's move first on the quick things. Those who joined first time, I'll give you in 1 minute very quick overview about the medical MCQ for all. And we recently started the EMREE residency program as well, Emirates Medical Residency Entrance Exam. So, website is also on the name of EMREE Prep, EMREE, EMREE Prep. So it was one of the wonderful websites. So those who are preparing or friends preparing for EMREE, just let them know that we also started this EMREE program as well. Along with this, so we provide a thousand MCQ book, ebook, online subscriptions, coaching, data flow services, short package, mobile application. So those who did not download it yet, the mobile application, they can download mobile application. Those who do not have link, send me the message so we can do later on. I'll pass on the link as well. And we have one short package for those who specially second trial or third trial. So that is excellent package as well. Little intensive course. I myself is Dr. Munjal Pandya. I'm a hemato-oncologist and bone marrow transplant fellow in Ahmedabad, India. So we'll be in touch. I have a experience of treating hemato-oncology for almost close to 20 years now and treating 100,000 patients so far. This is our quick team. Dr. Arti is a consultant pediatrician. Dr. Mehdi, internal medicine. Dr. Ankit Patel, gastroenterologist, Sikha Dipali, and bit long team with Dr. Anjali based at UAE looking after the data flows and Pallavi, as you know. This is our latest updated hard copy book, and there are lots of discounted big offers. Packages are also there, so you can inquire that later on. And data flow services, as I told you, we have a excellent mock test. One thing I would like to comment to the all doctors that on the website I'm seeing very less people are utilizing this excellent facilities of mock test. I think it is one of the best, and believe me, we created, so I mean still we are working on it. So excellent hard work we did it so far to create this that mock test, right? So I urge and I request everyone, those you are using website, use maximum mock test, because by doing the mock test you will get to know the exact score, how much you are doing, what's your score before going to the exam, and you will definitely get to know your strength as well as your weakness, so in which area you need to work more hard on your subjects for exam preparation. That would be great. So there are unlimited hundreds of mock tests are available on the website, and we I myself also posting one mock test on the website, so everybody can use maximum mock test, especially exam going, right? So that's it. So let's, these all are the various combo things. So you can inquire. One of the best combo we recently designed is that, just one last minute, I'll tell you. If you go for only one online coaching module, this all 10 things absolutely free with your package. So just subscribe only one coaching package. You get hard copy book free, you get ebook free, you get subscription free, you get WhatsApp subscription free, mock test free, video library free, weekly mock test free, mobile application, everything. I mean, so you don't need to struggle and worry about this. I'll just make the mic mute because again, people are asking me. So I'll make my mute, right? So somebody wants to interact, they can unmute. Fine, fair enough. So that's it. And last but not least, most important thing, if you are really, I mean, enjoying my coaching on this medical MCQ for all, there are excellent videos are uploaded. Everyone must subscribe, free access, don't need to pay even single penny, right? Excellent videos are uploaded by me and my complete team of pediatric, gynec and all. So this all videos are uploaded end of the session. We'll upload this video here as well. So you subscribe, you get all more this notification. Plus, you will also going to get excellent past this mock test. And one thing is sure, there is no repetition of questions. So every mock test there is a different questions and different complete concept clarity. So I strongly recommend two things: mock test you do on the website, and this, if you miss somehow the class, right, or the things mock, you go on the website medical, I mean sorry, YouTube channel medical MCQ for all. You can have a lot of videos there. That's it. So that let's start. The first questions in front of your screen: a 65-year-old Caucasian male presented with the Paget disease, presented with 3 months progressive worsening lower back pain and hip pain. On examination, there is a large tender mass in one of his leg. Lab shows elevated ALP, that is alkaline phosphate, ESR, LDH. On imaging, pelvic X-ray shows a sunburst pattern and Codman's triangle. What is the diagnosis? So if you see this X-ray, this is a picture of X-ray, right? So don't get surprised. You get a lot of picture in the X-ray pictures. So this is like a sunburst, just little more highlighting the things, right? So this is a bone, and this is a disease part with a sunburst, like rising sun. Now, when we are small kids, right, we are drawing the sun, right? This is how the sun rays. So this is a sunburst pattern. So what could be the diagnosis? So is it osteosarcoma, Ewing sarcoma, chondrosarcoma, liposarcoma, Paget, vitamin D disease? Those who are joining the first time, let me tell you once again this excellent important triad. Any MCQ you are solving now onwards in your practice for your exam preparation, you must know this triad. You must know the investigation, you must know the diagnosis of the scenario, and you must know the treatment. So they have here diagnosis, they asking the diagnosis, right? So they will ask in exam DHA, the MOH, SMLE, whatever the exam you give, they either ask you investigation, they either ask you diagnosis, they either ask you treatment. These are the main questions in the exam. So they are asking here the diagnosis now, but I want to know the investigation. At the same time, I want to know the treatment as well. So now you post your answer in the chat box, and we'll start now discussing these questions bit in detail. Yes. Post now your answer in the chat box. Yes, okay. So diagnosis is done by the biopsy. That is what Dr. Pankaj is saying. So that's correct answer. Absolutely, diagnosis is done by the this biopsy. So what could be your answer, Dr. Pankaj? Is it osteo, Ewing's, chondro? What's the diagnosis? Yes, Dr. Priya Siju. What's your diagnosis here and why?
It's osteosarcoma.
Osteosarcoma. So, what point favoring the osteosarcoma? Let's discuss. And why not Ewing sarcoma? That we'll also discuss. Our job is not just to give the answer, but our job is to exclude all the things, whatever the answer. Rest of the options we need to exclude as well. Right. So, now tell me little bit about osteosarcoma. Whatever you knows about osteosarcoma. What is the age of the presentation? What is the commonest site of the presentation? How you diagnose osteosarcoma? Right, how it differentiate from Ewing sarcoma? Tell me, Prija.
Um,
Commonest question in exam for DHA, had OMSB, all very favorite questions. I had given you a lot of clue, obviously, right?
yes.
Yes. So what do you know by, I mean, what you have impression in your mind about osteosarcoma? In general, I mean, your answer we'll discuss whether it is right or wrong. But what if I can tell you that osteosarcoma patient comes in your emergency room? What's the impression in your mind? How the patient presents? You must know, na? You must know.
Yes. The symptoms are having bone and joint pain.
Bone and joint pain. So which bone is commonly affected? Upper limb, lower limb, skull, back, spine, pelvis, hip. Which joint commonly it's you see usually?
Long bones of
Long
legs.
bone. Long bones of legs. Okay, fine. So what's the presentation?
The pain is come and go. It's on and off pain.
Okay, fine. So pain, probably difficult movement, swelling. These
And
are
there will be
the
swelling.
right. Is there any age, specific age where the osteosarcoma versus Ewing sarcoma seen? Do you know any age, right? This is a common age, sir.
Even
Like
sarcoma, I think in younger age group.
1 to
Even
10.
sarcoma.
okay, and osteosarcoma,
Osteosarcoma also
What is
most common between 10 to 30, 20 to 30, but it's also occurs in 60 plus also.
fine, fair enough. And this all elevated there, alkaline phosphate, ESR, LDH, all elevated in osteosarcoma.
No idea, sir.
Sorry,
I
no
I don't know,
problem.
sir.
So no
Okay.
problem. It's fine. I'm happy at least you are interacting. So your
Okay.
homework is to go and read two topics today after my class, whenever you get
Okay.
time. Osteosarcoma and Ewing sarcoma. I will
Hmm.
give you complete explanation. This is a
Okay.
Codman's triangle. Codman's triangle or periosteal reaction seen in various bones lesion, including osteosarcoma, most common. So most right. So they are saying sunburst. Both the signs they are given. Sunburst appearance, right? Sunburst appearance is this, and Codman's triangle. So this is Codman's triangle. There is a formation of triangle. So they are getting the name of Codman's triangle. So this is a head-to-head comparison between Ewing sarcoma, osteosarcoma, right? And another is a osteoid osteoma, that is a benign condition, right? These both are the malignant condition. This is a malignant tumor. This is a malignant tumor or cancerous tumor, right? So what is the osteosarcoma first or osteogenic sarcoma? Both are same. Somebody is saying osteosarcoma or osteogenic sarcoma, both are the same thing. So X-ray appearance is sclerotic destruction causing. So there is a destruction or sclerosis causing the sunburst appearance or Codman's triangle. Most accurate diagnostic test is a CT scan of the leg. So you need to do the CT scan. This is the investigation, right? Obviously, initial is a X-ray, right? But they are asking. So this is again question. So whenever they are asking any investigation, diagnosis, right? Or which is the investigation? So there are how they ask in the exam: initial investigation, based investigation, most appropriate investigation, highly sensitive and specific investigation. It's all word, but you need to have complete clarity, right? What is initial investigations here? If they ask osteosarcoma, initial is obviously X-ray. Nobody is directly going to go for the CT scan. So initial is X-ray, but if they're asking based, then CT scan, right? So they are asking most accurate. Most accurate means based investigation. So CT scan of leg is an important investigation, and therapy is a chemotherapy and surgery. So this is how we treat, or being a medical oncologist, osteosarcoma patient, right? First 12 weeks we give NSCT, means neoadjuvant chemotherapy, means pre-surgery. Then we do, after 12 weeks we do the surgery, and then adjuvant chemotherapy for at least 6 months. So total treatment lasts for almost 9 months, 3 months earlier and 6 months later, and in between surgery. So this is a standard treatment of osteosarcoma. So that is why this is neoadjuvant chemotherapy, surgery, and then adjuvant chemotherapy. So this is general, for your understanding, the treatment of the osteosarcoma, right? And we use the MAP protocol: methotrexate, adriamycin, and cisplatinum. P for platinum, methotrexate, adriamycin, and cisplatinum or platinum. So this is a standard treatment. They either ask you the treatment or based initial investigation and sunburst as well as Codman's. So you must know these high yield points. What triangle? Codman's. They may not ask you sunburst. They may ask you Codman's. So you must know that is in the osteosarcoma. What is the Ewing sarcoma? Onion skin pattern due to lytic lesion. So the biggest difference is a sclerotic lesion. Here the lytic lesion. So both are different. Sclerotic is different from lytic lesion, right? And there is a periosteal elevation, just right. There is a no sunburst appears, there is no Codman. Most accurate test analysis for the translocation between 11 and 22 via bone biopsy. So how you diagnose? Once you do the bone biopsy and you do the analysis by fish, you can do the fish, and there is a translocation of 11-22. So you must know translocation between, what is the translocation in CML, what is translocation in Burkitt lymphoma, what is translocation in acute myeloid leukemia M3. Anybody wants to try this question? High yield question in exam. Translocation in CML, like here translocation between 11 and 22 chromosome. So there are 23 pairs of chromosome. Let's go back to little cytogenetic. So this is a 1 and this is 23. So this all pair of chromosome 23, total number is 46 chromosome, right? Last is called as a sex chromosome. It is XX in female, XY in male. So what they are saying, 11 22 means number 11 number chromosome and number 22 chromosome, there is a translocation, means some portion of 22 go in 11, 11 go into 22. This is called as a translocation, right? So translocation, like transfusion from one to another, transfusion, translocation, transcript. So translocation means they change the location. What location change? 11 number chromosome, some portion goes into 22, and 22 some portion of chromosome goes into the 11. That is called translocation, location change, right? So that's it. So can anyone try? Dr. Priya, would you like to try what translocation seen in a CML?
It's
Let me
922.
just 22.
Excellent. So this is most common 9 translocation 922. Burkitt's lymphoma. This all are high question, huh? High yield question. You don't need to just mug up. You need to
It
understand each
is
and everything.
a 8, 8 14 or 20.
8 and
Confused.
14.
14. Okay.
8 is to 14.
Excellent. This is a translocation 814. Everybody write down this whole exam question. In one question, at least I solved 10 question. So this is second question in exam. AML,
8 and
AML
21.
M3,
8 and
sorry,
21.
APL M3 translocation.
8 and 21.
Are you sure?
I think I'm sure.
I may confuse you. You have to stick to your answer.
No, it's 8 and 21.
Okay.
For AML M3, it is 15 is to 17.
Excellent. That is what the answer. 1517. Translocation 1517.
Yes, sir.
Right? And there are lots of translocation. Right? So there is a drug. Why this picture comes in, why translocation? You need to know why you need to know translocation. What is the advantage of doing translocation? Right? By knowing the translocation, there is a development of one gene called as the oncotype gene or oncogene, right? In which oncogene develop in CML 922, right? So portion of chromosome 9 going into 22. And there is a one gene development or oncogene develop. What is the name of that oncogene? BCR-ABL. Have you heard of this or not? Yes or no? Tell me yes or no.
Yes, sir.
Yes.
So
Yes.
this BCR-ABL, right? If you block this BCR-ABL means you are stopping the CML. So what is the pathophysiology? CML, right? There is an increased WBC count. There is a translocation between 922. And during this translocation, there is an oncogene developed that is called BCR-ABL, right? And this BCR-ABL cause excessive production of white blood cell. What does it mean? If you block the BCR-ABL, there won't be any white blood cell excessive production. So how you get to know, Dr. Binish, how you block this BCR-ABL? There is a one drug. Do you know the name of the drug, BCR-ABL blocker drug or targeted therapy? Which drug blocks the BCR-ABL oncogene? Imatinib. Have you heard of imatinib? Yes or no?
So,
Tell
yes,
me
sir.
yes or no.
Dastanib or imatinib can be used.
Yeah. Yes, excellent. So imatinib can be used. So imatinib is a drug of choice for this. So would you like to tell me what drug blocks this translocation 1517 in AML-M3 or acute promyelocytic leukemia? What drug?
So that is what I was about to say. That isn't 821 is the AML with maturation, and 15 and 17 is the promyelocytic, like acute promyelocytic leukemia.
Even me
That
30.
APL.
So APL, that is acute
Yes, sir.
promyelocytic leukemia. The FAB classification is M3, right? If I'm not wrong, right?
Yeah, M3.
That
That
you
is
see,
M3, and for
yes,
8 and 21 it's M2.
yes, that's correct. So I'm asking about now M3 APL or acute promyelocytic leukemia is equal to AML M3. Both are the
Yes, sir.
same thing. Number one,
Yes, sir.
right? So you see the translocation of 1517. So is there any drug meant in the market available which blocks this PML or this 1517?
Sir, all trans retinoic acid can be
Excellent.
used.
Wonderful. Wonderful.
Yes,
Wonderful.
sir.
So the oncogene is PML RAR alpha, right?
Yes,
PML
sir.
Hmm.
RAR alpha. Have you heard of it? Yes or no? Yes or no? Right? PML RAR alpha. So this, like in BCR-ABL, is the oncogene of this CML pathology. CML, the target gene is BCR-ABL. Right? Here the translocation is 1517 and the PML alpha, RAR alpha is a this oncogene. If you block this PML, RAR alpha, APML or APL will get under control, and that is why it is a drug of choice, and drug of choice is a ATRA, all trans retinoic acid. All
Yes,
trans
sir.
retinoic acid, right? It's a
Sir,
vitamin
what
A
is the
derivative.
drug of choice for AML?
Drug of choice for AML is all the AML would be treated in the same way. Let me tell you one more minute quickly if you guys are interested. I'm not in hurry. So just very quickly, the quick rehash of our hematology. I love hematology because I'm primarily trained in hematology, so I have more right. So BCR able. So say for example CML, right? Translocation 922, oncogene BCR able. This is how you have to remember. And drug of choice is imatinib. Is that clear? Yes or no?
Yeah. Yes, sir.
Same AML, especially M3. Translocation is, as we said, 15, 17. And this oncogene is PML RAR alpha, right? And treatment is a ATRA, all trans retinoic acid. It's a vitamin A derivatives, right?
So,
5, 10 questions related with AML. I'll quickly tell you in 1 minute. AML M3, right? Excellent prognosis. Excellent prognosis. There are 7 subtype: M0, M1, M2, M3, M4, M5, M6, M7. Many questions. Which is the most commonest AML amongst M0 to M7? It is M2. AML M2 is most common. 30% of the patient present with AML M2. So answer is different. If they ask in exam what is the most commonest subtype, so most common is M2. What AML has a best prognosis, the best prognosis means highest survival or curative chance, highest cure, that AML M3. 80% of the AML M3 or APL or acute promyelocytic leukemia, 80% of patient goes in remission, right? So this is the best. Which AML present with gum hypoplasia, or there is a monocytic infiltration in the gums? Anybody? AML M5, myelomonocytic leukemia, monocytic leukemia. The change the answer. This is AML M5. Which AML present with the DIC, disseminated intravascular coagulation? Niharika, any idea? Which AML present commonest amongst this? Or we are talking about M0 to M7. So again, the answer is a AML M3, APL, or acute promyelocytic leukemia, DIC, because this promyelocyte releases the substance from the promyelocyte that make patients hypercoagulable, thrombocytopenia, patient bleed. So any patients now onwards comes to your emergency, right, with a very bad count, CBC, right, or pancytopenia with bleeding, never ever miss the APLM3, right? So this is what the FAB classification, French, American, and British. So this is French FAB WHO classification. They divided AML in M0 to M7 subtype. Regarding the treatment, there are treatments. So let you guys are not getting bored, right?
No, sir.
Wonderful. So what is the treatment? This all questions in exam, high yield questions. So we are covering a lot of things at the same time, right? So the treatment of AML, right? So this treatment is by and large the same, right? But there is a 3 risk group, right? A good risk, or you can say low risk, intermediate risk, and high risk. This intermediate, good, and high, it depends on the cytogenetic, fish analysis, and multiple molecular marker. They categorize whether it is a low risk, intermediate risk, or high risk. The treatment, first treatment given to any patients of leukemia is called induction chemotherapy. And this induction chemotherapy remains the same for all three. Where the treatment change is the consolidation. Consolidation means once you had given the chemotherapy, the goal is to make the bone marrow in remission, means there is a less than 5% blast in the bone marrow. Once you keep this patient in bone marrow in remission, the next treatment, which is a treatment for the residual disease, that is called as a consolidation therapy. So in low risk, induction chemotherapy 1 followed by 4 consolidation therapy maximum. This is what the international protocol, and this is how I treat in my OPD and IPD for last many years as per the guideline. Intermediate risk, induction chemo same, induction chemo same. Here the induction chemo same. The treatment change in the risk group. So what intermediate risk group? Induction chemotherapy same, followed by consolidation 1. This is one protocol, 1, 2, 3, 4 consolidation, or you go for autologous stem cell transplant. Autologous stem cell transplant. This is all the this is the consolidation therapy. Induction is same for all three, irrespective of anything. And last, high risk patient, induction chemotherapy same, followed by allogenic bone marrow transplant. Allogenic bone marrow transplant. Allogenic means you need some match donor, sibling, HLA match, human leukocyte antigen match, right? Autologous means patient's own stem cell, patient's own. You don't need to look for anybody who can donate the stem cell, patient's own. That is why it is called autologous. Auto means own. Allo means foreigner or other person. So autologous or allogeneic bone marrow transplant. So you see how the treatment varies from different risk category. Why you want to do the bone marrow transplant in high risk? Uh, right? Because if you do just induction and only just simple consolidation 1, 2, 3, 4, there are 80% chances that patient may relapse. And once relapse, again the treatment is bone marrow transplant. Right? So depends on the risk categorization you need to treat the patient. Again, questions. Sir, what is the treatment for APL then? So APL has a good prognosis. So again, the thing is same, induction, consolidation you give. Only thing you need to add in treatment is ATRA as that's it. This is only change. So M0 to M7, right? Whatever the things, once you diagnose M0 to M7, categorize in which category it is. If there is a M3, the only change is to add the ATRA. Otherwise, M0 to M7, except M3, treatment is the same. Depends on the risk factor. Is that clear? Somebody asked me, what's the treatment of AML? This is the treatment of AML. Who asked, right? Any query, doubts? Those who ask, any query, doubt?
So, what is the drug of choice for AML? It's a therapeutic drug for
Excellent.
AML.
So AML, any AML, the chemotherapeutic drug induction chemotherapy means first chemotherapy after the diagnosis. We give 7+3 regimen. The name of regimen is 7+3. The 7 is cytarabine. You want to remember or write down name cytarabine, and three
And
days is
anthracycline, I guess.
daunorubicin. Daunorubicin, that is anthracycline.
Hmm.
Doxorubicin and donorubicin is
Yes,
the
sir.
anthracycline. So 3 days anthracycline and 7 days cytarabine, right? And what drugs given in the C1, C2, C2, C3, C4 consolidation is a high deck. We call it as a high deck
Mhm.
as per the book. High dose Arac or cytarabine. So high dose cytarabine that is given in 1, 2, 3, 4. That's it.
So
So this is
this
the
is
drug of
tested in
choice.
सर
Sorry,
ये टेस्ट होता है एग्जाम में ये ड्रग ऑफ लाइक
sorry, I'm not getting your question, Niharika.
सर does this tested in exam?
Yeah, they may ask, they may ask, right? There are a lot more to do, but I don't want you to become a hematologist as of now. If you guys are interested, I'll take separate complete hematological marathon mock test, right? Where we'll discuss everything. What is the side effect of cytarabine? What is the side effect of donorubicin? What is the dosage? Main side effect of cytarabine is a keratitis, right? Cerebral dysfunction. Donorubicin anthracycline is a cardiotoxic drug. You need to monitor 2D-ECO, but probably they won't ask you that much in detail. Whatever the high yield points for DHA are, the MOH, OMSB, SMLE, I'm just trying to cover that because I know I'm doing this for last more than 10 years. So I know how many questions they ask and how they ask in exam. So I'm just stick to that dot points only. You understand? But if you have any questions in between, I would be glad to answer you this. So far, is it clear everyone that how we gonna treat this patient?
Sir, there's a new drug for AML now by the name of quizartinib. So, I
Yes.
mean, like this was the latest question that was asked in Emily. So, sir, I mean, like if they ask us the drug of choice, the quizartinib
Probably,
or cytarabine.
this MLE people are little advanced. Don't take it otherwise.
Yes, sir.
Just to save the time, I'm not going. But if you guys
Okay.
are interested in AML, ALL, CML, and CLL, four different entity, right? How
Yes,
to
sir.
diagnose, what's the presentation, how you investigate, how you treat, what is the high yield points. We'll take one leukemia lecture. You just post me in the group what exactly you want. So
Okay.
there must be lots of confusion amongst you only, right? How you
Yes.
differentiate sir acute from chronic, how you differentiate ALL, AML, CML, CLL, blah blah, right? So we can discuss bit in detail. So I'll switch to the next questions, right? There are another drug. There are anti-FLT3 drug. High risk. How you get to know this high risk? So there is a gene. There is a gene FLT3, NPM, PM1, CEBPA. These all are the genes they have find out. And there is one drug for the FLT3 or anti-FLT3. Like drug against the CML, right? BCR-ABL you block by imatinib, it will control. High risk FLT3 gene is present. There is a one drug, right? If you block that drug, right? If you give that drug, it would be controlled. Anyone knows the drug name? Anti-FLT3. Go and read it.
Sir, is it midosaturin?
Excellent. Wonderful. It is
Tora,
midostaurin. Yeah,
Midostaurin, yeah.
midostaurin, and the brand name is Rydept,
Yes, sir. Yes.
RYD, Rydept. Right. So this is a credit question. So I'm glad that you know much things. So let's move to the next question. So bottom line is that our job is not just to know the questions. Our job, being a doctor, being an expert, this is how you will learn, right? You don't need to just mug up sunburst is osteosarcoma. Otherwise, the rest of the things you knows nothing. You need to know each and everything about the MCQ. What is Paget disease? So there are in one question, how many questions you make? Right, we how many questions we started from Ewing sarcoma and ended up with the leukemia treatment. You must know this all absolutely a high yield point, right? So you must know how you differentiate from Paget disease and osteosarcoma. So this is your homework. You need to know why you right, what happens in Paget disease, alkaline phosphate, right? Then what happens to ESR, what happens to LDH, what happens to calcium in Paget disease, and what happens in the osteosarcoma. Is it the same? Is all elevated in both? You, if you don't know, you go and read it. That's the homework, right? That our job is not just to get the answer. Probably they may ask you other questions. So that is why I'm discussing a lot of question in one question. So that's it. So this is what the thing is: osteosarcoma, MRI or CT to evaluate extent of disease. Biopsy is the best. Staging is with the CT or PET CT scan is now available, right? PET CT scan, neoadjuvant surgery, and then adjuvant chemotherapy, as I told you. So that's it. And Paget is a risk factor. So HYF is a high yield fact associated with sunburst periosteal reaction that we seen in X-ray, history of Paget disease, and the radiation exposure. So these are the risk factor. Let's jump to the another very interesting next question. CREST syndrome. Which one of the following is extremely specific test for the CREST syndrome? Right? So we'll discuss again like osteosarcoma. It would gonna be a excellent, super duper interesting today. So options are ANA, anti-centromere antibody, anti-CCP, anti-dsDNA. Drug of the choice. Again, next question is what is the drug of choice for hypertensive crisis in systemic sclerosis? Right. So that is another question. So first question we try to solve this, and then we try to solve this, and we try to solve more 20 questions related with this. Right. So now you can post your answer in the chat box. Yes, iPhone. Who is iPhone? I mean, somebody is posting iPhone as a name. So posted T814 for Burkids. So that's correct answer. Next time if you join, just put your name so I can interact. iPhone, I don't know
Yes,
who is iPhone.
that's me. So Beanish.
Who? Oh,
The
sorry.
Beanish. Yes, sir.
Yeah, sorry. Because there are four,
Um,
five iPhone. You understand?
okay, sir.
So I
Yes, sir.
don't know now who, which iPhone. No problem. Yes, Dr. Noha, can you little bit comment on this, Dr. Noha? Dr. Noha,
Sir,
yes, doctor. So your answer is what? Anti-DS DNA?
that's what I think. I'm not sure.
No problem. Don't worry, my sister. You just answer. I'm happy at least you are interacting. Many people are just sitting as a guest. I don't want anyone to be a guest because I'm taking a lot of pain for last years and years to take a conduct this thing. So you should be a more sincere. "No, I'm not going to go for exam." You are going to go for exam. So anyway, so what is anti-dsDNA, Noha? What is the full form of anti-dsDNA? You know each and everything. In my class, you know each and everything. We don't need. We are not a robot. Yes,
It's
Noha.
anti double standard deoxyribonucleic acid. I
Fair
think
enough. So
DS is for
DS,
double standard.
right. So DS is double strand. So Dr. Noha, right? Your answer is this is wrong, basically.
So
So
it is
now you tell me.
anti-DS DNA is for lupus and SLE. It is
Okay,
not
so
for
first
CREST.
fine. So Dr. Noha, now we are discussing, right? So you just keep your eyes and ears open. So try it. So now tell me, Dr. Binish, that this test where we use, what are the, if it is a positive, what it could be the differential diagnosis?
So
Those
it
who don't know, you
so
need to know all the things, huh? This is not just for the answer. We'll discuss 10 question in this question. So one is, what is the, when the anti-dsDNA present What could be the differential diagnosis? First question.
SLE.
So it can diagnose SLE or lupus. The lupus, systemic lupus
Basically,
erythematosus. Yes, sir.
yeah, so this basically SLE. Is there any condition where you see the anti-dsDNA? Only one condition in this world where you can see the anti-dsDNA.
So patients with autoimmune hepatitis, I mean, even they show anti-dsDNA sometimes.
Fine, no problem. You tell me, I'll make a list, big list. So autoimmune hepatitis, say for example.
Yes, sir.
Okay, that's it. Anyone, it's open for all, not for Binish only.
Good
Open
afternoon,
for
sir.
all.
Multiple
So
myeloma.
try to use
Multiple
your
myeloma.
brain.
Good afternoon, sir.
Multiple
Multiple myeloma.
multiple myeloma. Have you seen the multiple myeloma ANA positive? Why the ANA is positive in multiple myeloma? Because multiple myeloma is not an
NPDS.
autoimmune disease.
So even for juvenile rheumatoid arthritis, it can be seen rheumatoid
Juvenile,
arthritis.
juvenile rheumatoid arthritis.
So okay,
NPDS again is positive.
Sorry,
so in rheumatoid arthritis also anti-dsDNA antibodies can be seen. So they are positive in that also.
rheumatoid
Okay.
arthritis.
Yes, sir.
Yeah. Whatever you are saying, I'm writing the list. Then we'll conclude as well. That's it. Anyone else? So you
Sir,
don't read the immunology or rheumatology.
anti-CCP antibody present in RA.
Anti-CCP is in RA.
Okay, so now anti-CCP. What is the full form of anti-CCP?
Citrulline
Like cyclinase
peptidase.
Sorry.
citrullinase.
Go one by one. We are not in hurry. We want to learn the subject. We don't want to mug up the subject.
So it is
Right?
anticyclic citrullinated peptide, anti-CCP.
Okay, fine. So anti-CCP is seen in which condition?
So in rheumatoid
RA.
arthritis, RA.
Okay,
Yes,
rheumatoid
sir.
RA, rheumatoid arthritis. Okay, fine, fair enough. Then anti-centromere antibody seen in which condition?
So
Crustin.
CREST syndrome.
CREST syndrome. So this is what the answer is, CREST syndrome. Now, can anyone tell me what includes in CREST syndrome? They may ask the question, all of the following including CREST, except. So you must know no, what is included in the CREST. Yeah, anyone can try.
Calcino.
Dr. Ravi, would you like to try, sir?
Calcinosis.
Sorry?
So there is
Sorry?
calcinosis.
1 minute. Dr. Ravi is trying. Let him try. Yes, Dr. Ravi. Don't hesitate. Right or wrong, forget about it. Don't worry.
Calcinosis.
Calcinosis or carcinosis? Ravi, carcinosis or calcinosis?
Calcinosis.
I'm not getting you.
CALLL. Calcinosis.
Carcinosis. Okay. R for
Raynaud phenomenon.
Raynaud's phenomenon.
sorry, Raynaud's phenomenon.
Raynaud.
Raynaud's. Then
E for
E for
esophageal involvement.
esophageal
Esophageal
involvement.
dysmotility. Yes, sir.
Wonderful. So basically esophageal involvement or dysmotility. S
Yes.
for
So
T for
sclerodactyly.
telangiectasia.
Sclerodactyly, yes, sir.
sclerodactyl. And T for
Telangiectasia.
telangiectasia. So here not carcinosis, it's a calcinosis, just for your knowledge. Right?
Yes, sir.
Dr. Ravi, is that clear?
Yes, yes.
Right. So this is what we need to know. Though they did not ask what is the full form of a CREST or like again there is a lots of things. There is one other Vactral syndrome. Have you heard of Vactral syndrome? Yes or no?
Yes, sir. Vactal syndrome.
So related with this, you need to know we are not a robotic. We have a good brain God has given us. So you need to know. So now those who don't know what includes what six things include in the Vactral, go and read Vactral. I am just now stick to CREST now. So those who don't know Vactral, there are six things in Vactral.
Yes,
Like
sir.
there are five things, right? In CREST syndrome, there are six things in Vactral, right? So you must know. Go and read it. So calcinosis, Raynaud's, esophageal dysmotility, sclerodactyl, and telangiectasia. That is CREST. So first tell me, Dr. Ravi, CREST is a systemic sclerosis or it is a localized sclerosis? Localized or systemic?
Systemic, sir. Systemic.
Sorry,
Systemic.
because you need to know, na? You need to
Yes.
know.
Systemic
We have
sclerosis.
given that CREST syndrome, which of the following is extremely specific test? So now this is the CREST syndrome, right? It's a localized scleroderma. Third thing is a which extremely specific test. So you also mentioned the for CREST anti-centromere antibody means anti-centromere ACA, anti-centromere antibody. ACA, it is called ACA. Like CCP, it's a ACA. So anti-centromere. So now can you tell me what is a, it's the same question. Here, instead of CREST, systemic sclerosis. I change the question. Systemic sclerosis. Which of the following is extreme specific test? Now, tell me, what's the answer now? For CREST, you told me anti-centromere antibody. ACA. Now my question is changed. It is not localized. Now it's systemic sclerosis. Which of the following or any other? If I am missing some here, you can tell me, sir. Yes, Vinesh. What is the
Sir,
answer?
ANA, anti-nuclear antibody.
ANA, anti-nuclear antibody.
Yes, sir.
ANA.
Yes, sir.
Okay, so ANA is a general test, doctor. Let me tell you little bit about ANA. ANA is anti-nuclear antibody. So this
Yes,
is
sir.
a screening test. This is how we use in clinical practice in day-to-day life. So
Yes.
whenever I am suspecting any patient is suffering from autoimmune disease, right? Autoimmune disease like joint pain, skin changes, arthritis, rheumatoid, blah blah. If I'm thinking clinically, right? I'll screening test. I'll do ANA. There are two things, right? In ANA, this is an absolute protocol how you approach in clinic as well. If patient comes to you tomorrow morning, right, ANA, there are two things. You did ANA, you are suspected by history and physical examination. You suspected that this patient has an autoimmune. You did ANA. There are two results. Either ANA is positive, either ANA is negative. ANA negative, almost the story is over, almost right. It is though it is not 100% that ANA negative does not rule out the autoimmune disease, but there is a reasonable chance that he has a no autoimmune disease. Am I right or wrong, Dr. Binish? And
Yes, sir.
if positive, then there is one other further test called as the ANA profile. Is that clear? Yes or no?
Yes,
In
sir.
this ANA profile, we have a many profile. We have a lipid profile. Have you heard of lipid profile, ANA profile, iron profile? Yes or no? At least tell me yes or no.
Yes, yes, sir.
This ANA profile will put lots of various antibodies like anti-CCP, anti-centromere antibody, anti-dsDNA, RO, RO, LA, right? Right? Anti-smooth muscle antibody, anti-mitochondrial antibody. So lots of they put and they conclude that okay, this antibody is present. Now this is the disease because you need to know, na, autoimmune disease is a big umbrella, right? Autoimmune disease is what? Rheumatoid arthritis, autoimmune, juvenile rheumatoid arthritis, autoimmune disease, mixed connective tissue. There are a lot of things in this autoimmune disease, systemic sclerosis, autoimmune disease, right? Nephritis, autoimmune disease. There are a lot of vasculitis, is autoimmune disease. So you want to make a name, right? Which autoimmune disease? So to know the idea of the which autoimmune disease, that requires ANA profile. Is that clear? Yes or no? At least tell me yes or no.
Yes.
Wonderful. So we need to know all the things ractic related with this. So now can anyone tell me how you differentiate systemic sclerosis from the CREST in terms of presentation, in terms of test, in terms of specific test, in terms of treatment, how you differentiate? Because we need to know three things: investigation, diagnosis, and treatment. So now we'll jump to the treatment, though they have not asked, but in your exam they ask how you treat the CREST. Now, what's your answer? You need to know.
Drug
Never
of
ever forget.
sir for CREST is mycophenolate.
CREST is mycophenolate. What is
Sir,
mycophenolate?
so it's the drug of choice for CREST, sir. And the newer drug is
Drug of-
tocilizumab.
Okay.
But sir,
So, yeah, sorry. Go ahead. I'm
Yes, sir.
listening.
That's it, sir.
Okay, so what is a mycophenolate basically? Under which pharmacological group it falls into? Like cefadroxil is a cephalosporin,
Yes, sir.
right? Amikacin is a this various
It
anaerobic
is
drug
an
is a
it's
yes,
a immunosuppressive agent.
immunosuppressant agent, mycophenolate, right?
Yes, sir.
Okay, so you cannot give steroid. That is also immunosuppressant. Why you want to directly give the mycophenolate? Steroid is a years and years very known drug and autoimmune. All transplant I done more than 500 or so for bone marrow transplantation. My center is also doing renal transplant, kidney transplant, liver transplant, right? Even lung transplant our center is doing, right? So they are using lots of patients. In most of the, not, I'm in hematology. I'm a bone marrow transplant guy, but they are using steroid for renal transplant. They are using steroid for liver. They are using so why not steroid? Why directly jump on the mycophenolate or cyclosporin, right? You get my point. Or sirolimus, right? This is all the immunosuppressant drug which commonly used is for the autoimmune disease or immunosuppression. Anyway, so just go and read more literature, right? So
Yes.
no worries. So 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 this is the things. I'm just get back to the literature now. This is the CREST syndrome, calcinosis, not carcinosis, Ravi. So calcinosis, so this is calcinosis, Raynaud syndrome, right? Raynaud syndrome, peripheral vascular, esophageal dysmotility, sclerodactyl, and telangiectasia. So all pictures given here. So this is all this CREST syndrome. The short is a CREST syndrome, right? So this is excellent slide. I got it for you. Just to differentiate, CREST is what? CREST is a limited scleroderma and diffuse or systemic scleroderma. Here the ANA pattern is a centromere, so anti-centromere antibody. That is a specific test, right? And here the speckled, right? So here the antibody which is present in CREST as the questions, our main stem of the question, based sensitive test for CREST syndrome. So this is anti-centromere antibody. And here you need to write down not only ANA or anti-dsDNA, it is CAL70, anti-SCL70. Dr. Niyarika, is that clear to you?
Yes, sir.
Right. So this is anti-CL SCL70 antibody. Right. So this is all specific questions. Probably they don't ask you this. They may ask you which is the specific test for diffuse scleroderma. Answer is anti-SCL. Pulmonary involvement. This is a differentiating point. More commonly associated with pulmonary hypertension. Very important. So whenever you see CREST syndrome, look at the ask the patient breathlessness. Look at the 2D echo. Look at the pulmonary artery hypertension. Right. If it is present, what is the drug of choice? Somebody can tell me. Meanwhile, I'll differentiate. And here also lung involvement. Involvement here, yes. But the pathology is pulmonary hypertension. Right. Lung parenchyma is normal. Here, no pulmonary involvement is that, but no pulmonary hypertension. Here, the interstitial lung disease and alveolitis, little different pathology. Here, pulmonary hypertension, right? Vascular problem, problem in the vessel. So they usually present with pulmonary hypertension, not alveolitis, not interstitial lung disease. They are not present with the pulmonary hypertension. They have alveolitis and interstitial lung disease, but lung involvement is there, right? And renal involvement is not there in CREST, which is in the renal involvement is commonly present. Usually renal sparring. Sparring means not involved. Like potassium sparring drug. Have you heard of this word? Potassium sparring drug? Yes or
Yes,
no?
sir. Yes, sir.
Iron
Like
lactose.
that, sparring means not involved. So usually renal is not involved. Here the associated with scleroderma renal crisis. Scleroderma renal crisis, SRC, can typically be potential with glucocorticoid use. So if somebody has a systemic sclerosis, patient has a renal involvement, they are on the steroid, it will worsen. So what is the drug of choice if somebody present with a renal hypertension with systemic sclerosis? No option. Anyone? This is the exam question.
AC inhibitor?
Excellent. ACE inhibitor. ACE inhibitor is the drug of choice, right? So scleroderma renal crisis, I told you everything about, so I'm not going what repeat. Anti-centromere antibody, right? And ACE inhibitor is the drug of choice for a renal crisis of scleroderma. Is that clear?
Yes, sir.
Yes or no?
Yes, sir.
Yes.
Yes.
Wonderful. So that's it. Switch to the excellent again, complex questions. So far clear, everyone, anyone? Dr. Samir? Dr.
Yes, sir.
Samir, are you there?
Yes, yes.
Wonderful, 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 wonderful. I'm enjoying. Hopefully, you are also enjoying. So,
Sure.
third questions in front of your screen. Again, very important, very extremely high yield questions. Right. So, let's discuss. 59-year-old obese woman underwent a coronary artery stent procedure. She is a well controlled type 2 diabetes. Operation was successful. However, after 1 week during recovery, the patient complained of severe chest pain and shortness of breath. Her heart rate was 115, blood pressure is 107 by 89. Following the resuscitations of the airway, breathing, and circulation, that is ABC, electrocardiogram shows sinus tachycardia, right axis deviation. The most appropriate treatment is warfarin, intravenous adrenaline, altiplase, salbutamol, intravenous heparin. Here, there are lots of questions to discuss, at least 10 questions to 20 questions. My triad, don't miss it. First of all, anybody who is interacting need to know the diagnosis or what could be the differential diagnosis, right? They are directly asking the treatment without giving the diagnosis of scenario. So you need to know what could be the diagnosis. Then your this job is very easy, very easy. They are asking all. This is all treatment. But how did you get to know without diagnosis to jump on the treatment? Everything is in the scenario. If you keep your eyes and mind open, you get the answer in the scenario. Yes, Dr. Kens. Any comment, Dr. Kens?
Yeah, it's a massive PE.
It's a massive P. So
Yeah.
let's discuss word by word. What do you mean by massive and what do you understand by non-massive?
Massive is with unstable vitals initially, with
Unstable
ROV
vital.
dysfunction.
So, okay. So what is the definition of vital stable? Sorry to go on the basic things. Don't take it otherwise.
Yeah.
So what do you mean by this?
He had a arrest actually, I think, initially.
Where
Means,
it is given that this is arrest?
no,
From
no.
where you get to know that this is arrest? Yes, Kens.
Following the
So this
resuscitation of the airway, breathing, and circulation.
is an emergency. I mean, chest pain
So
patient
I
is
thought a
there.
resuscitation, when they say, I thought they must have gone for.
Fair enough. Do you know the definition of
So for
unstability?
unstable, the BP has to be around 90 by 60.
Unstable BP. Yeah.
Yeah, BP has to be around 9. Systolic has to be down like 90.
Okay, great. So first and foremost things, just keep and fix your head in mind. Anything less than 90 systolic BP, you can consider this patient as an unstable patient until proved otherwise, and especially when there is a history of chest pain. So this patient is not very unstable. Blood pressure is quite good. Pulse rate is high, tachycardia. So high 150 is not unstable patient. If patient has a fever, even if I am seeing one patient of fever, they have 120, 130 pulse. You go and check in your ward tomorrow. Don't believe me. Go and check. Put a pulse, put a pulse oximeter and check the pulse. Patient has 101 fever. They at least have 120, 130 pulse. High grade fever, right? So first of all, decide any patients whether it is a stable or unstable patient, right? So as per the book definition of unstability, unstable. If you want to tell any patient as an unstable patient, just in general, huh? Right? Systolic blood pressure is less than 90. Patient has history of chest pain. Patient has neurological,
Altered mental status.
yeah, neurological involvement, right? These are the or shortness of breath with extremely high more than 20 30 respiratory rate. This patient considered in general as unstable. We don't see anything unstable in this patient so far as per the book picture, right? You open up the book, read the master of the board, they had given the clear cut. It is given in a cardiology and CPR section. They had given this definition what I told you of instability. Anyway, So doesn't looks major unstable patient. So do first tell me anyone what could be the diagnosis. Without diagnosis, we cannot jump whether it is acute coronary syndrome, whether it is a esophageal rupture, whether it is acute pancreatitis, whether it is a pulmonary embolism, or whether it is some complication of coronary artery stent was placed. First line is that 59-year-old obese woman underwent coronary artery stent procedure. So is it something wrong in the procedure or complication of diabetes? You need to know.
Sir, it could be stent thrombosis as well.
Stent thrombosis. So
Yes,
how
sir.
did we get to know this is a stent thrombosis?
So, if a blood clot has formed inside the stent, so because there's
Usually
pain
not
after
happen.
the
Usually
stent.
not happen. Usually not happen. Why? Because it's a stent is now drug eluting stent. Do you know that drug eluting stent and drug non-eluting stent?
No,
Yes or
sir.
no?
No, sir. No, sir.
So let me tell you. Let me tell you. So what is that? So say for example, this is coronary. Example, it is 90% block. This is atheromatous plaque, right? Little blood is going from one side to another side. This is all atheromatous plaque. This is also plaque. So drug-eluting stent, what do they do? This is picture of coronary angiography. Say for example, right now, what is the picture? Now they do the balloon angioplasty. We call it balloon. So what they do? They entered one catheter. There is on the catheter there is a balloon, right? So this is like a catheter, and in this there is a balloon. So first they enter the catheter, they inflate the balloon. So what it will dilate. So that is called angioplasty. Angioplasty means reconstruction of stenosis, angioplasty. And after angioplasty, right, on top of that, there is a one mesh. So what this mesh will adherent to the wall of the endothelium after angioplasty, after dilatation. And this mesh will release one drug which prevents the clot. The biggest advantage of these things, right? So this is called as a drug eluting stent, given in the books very well. It is not nothing new. It's done from years and years. Drug eluting stent. So in stent there are two stent. There is no drug which is released, and there is a one stent which releases the drug from the stent. It's inbuilt right in the stent. So this is now it's replaced almost across the globe. People are using the drug eluting. What is the advantage of drug eluting stent? It secretes the drug which prevents the clot. Is that clear, Doctor Vinesh? Yes or no?
Yes, sir. Yes.
Right, so this is drug eluting stent. So usually nowadays it's immediately, and this is what I mean, how many days, right? After 1 week, after one
Okay.
week something happened wrong. So within 1 week there are extremely rare chance, right, after angioplasty and that, right? And do you
Okay.
think so what is the diagnosis again? So say, let me ask you Dr. Bini's question, right? You say coronary artery thrombosis, right? That is what your diagnosis or suspect?
Yes, sir. So stent. Yeah,
Shall
Fine.
I'll
So,
go
so,
with the
so,
PE
so two
only.
question. So two question for you for discussion. Why patient has a right axis deviation? Number one. Do you think in coronary thrombosis there is a right axis deviation develops? Yes or no? First, yes or no?
So
It
no.
can develop.
So like
What
it's the
pathology
right.
can cause coronary artery thrombosis can cause right axis deviation? Again, question. What are the causes of right axis deviation? If you have right axis deviation
Yes.
on ECG, what could be the diagnosis? Again,
Right
Binny's
heart
question.
failure.
the hyperkalemia, acute
Right heart
lung
failure.
disease. Yes, sir. The
Right heart
COPD.
failure. COPD. Okay, I'll write down the list. What you say, I will write down. Then we'll
So
Right,
even
discuss.
myocardial
Right
infarction could cause.
ventricular
right
hypertrophy.
ventricular hypertrophy.
That is written. Right ventricular hypertrophy or right heart failure or right ventricular hypertrophy. Right ventricular hypertrophy. Okay, fine. Where you get the
Pul-
right axis. What
Pulmonary
else?
arterial hypertension.
Pulmonary artery hypertension. So you don't want to add pulmonary embolism,
Pulmonary embolism, sure. Yeah, it is there.
right? So now again,
Pulmonary
Dr.
embolism
Binish.
causing RV dysfunction.
Okay, great, wonderful. And that eventually do the right axis deviation, isn't
Yeah,
it?
yeah.
So tell me, Dr. Binish, what pathology you can correlate or how you correlate coronary artery thrombosis with right axis deviation?
So in right axis deviation, So there's reduced muscle fat of left ventricle. So there's altered conduction pathway.
Conduction pathway. Okay. That is because of
Yes.
ischemia, you want to say?
So yes.
Okay. So why? So again, we'll go back to the question. 59-year-old obese woman underwent for coronary artery stent procedure. She is well.
Yes, sir.
And sorry, and so coronary artery stent is done. So some kind of IHD or coronary artery disease, there is a thrombosis. They did the stent or drug-eluting stent. That procedure is over now, right? She is well controlled type 2 diabetes. So she has a type 2 diabetes. Operation
Yes,
was
sir.
successful. That was fine. However, after 1 week, during recovery, patient complains of severe chest pain and shortness of breath. Shortness of breath. So what could be the reason in this patient for shortness of breath? Chest pain is okay, fine, I understand. Okay, probably coronary artery thrombosis or I mean recurrent ischemia or
DVT,
recurrent MI could be possible,
DVT, sir.
but DVT. Okay. So shortness of breath is DVT. So basically not because DVT, because of P basically, right?
Yeah,
DVT eventually does pulmonary embolism in
PE
that
only.
sense.
Yeah,
Only DVT
yeah,
doesn't produce a breathlessness. You can have pain, you can have swelling, you can have Doppler, insufficient blood flow, blah blah, right? That is in DVT. But
yeah, yeah.
P
But basically,
shortness of
pulmonary
breath,
emboli only.
embolism. Fair enough. Fine. So now this patient, if there is a coronary thrombosis, Dr. Binish, what ECG changes you expect in this patient? Forget about scenario. If you have coronary thrombosis or again coronary artery thrombosis, what ECG changes you expect in this patient?
Sir, in coronary artery thrombosis, so there would be ST segment depression, T wave inversion, and flattening of the T waves.
Okay, so is there anything you see in this scenario? Because they have mentioned ECG. ECG,
Yes,
they
sir.
have mentioned two things, sinus tachycardia and right axis deviation. Is it commonly seen in coronary artery thrombosis? Nothing is in ST segment. They mention absolutely okay.
No, sir.
So would you
But
like
we
to change the
see,
diagnosis?
sir, but we see that in PE, sinus tachycardia.
So what could be the diagnosis? Get
So
back to
we
the
see it
basics.
in PE, sinus tachycardia. We see in PE along with S1, Q3, and T3 abnormalities.
Fair enough. Fair enough. So now what is the diagnosis by the audience? Most likely diagnosis by the
PE.
audience.
Pulmonary
PE.
Pulmonary,
embolism.
pulmonary embolism.
Pulmonary embolism. So now we come to the conclude the pulmonary embolism. Right? Now second thing, tell me the ECG changes, three changes. ECG three things. I'll ask you. This all question in exam. P related. What is the commonest ECG changes? One question in exam. Commonest ECG. Listen the question. What is the most non-specific changes in ECG in pulmonary embolism? What is the pathognomonic or hallmark of pulmonary embolism in ECG? Anyone can try all these three questions in one question.
Commonest is tachycardia.
Wonderful. So one
Yes,
answer
sir,
is
yes,
given.
sinus
Sinus
tachycardia.
tachycardia is the commonest, number one. It is
Non-specific
salt.
is right axis deviation.
Sorry, right?
Right axis deviation. Right, no,
Right axis deviation is there, but not a non-specific. It's a specific rather than.
So
Anyway,
less
what is the
commonly is S1, Q3, and T3 abnormality.
Yes, sir.
no,
that
that
is
is
less?
pathognomic. That
No,
is
that is less
pathognomic.
common.
It is less. It is less. But if you see S1,
That is
Q3,
pathognomic.
T3, it is a pathognomonic. If it is present until proved otherwise, it is a MI. Sorry, pulmonary embolism. Right? What those who don't know what is S1, Q3, T3 means S wave. Right? This is a, let me draw. So you will again rehash your physiology. P wave represent atrial activity, Q wave, R wave, S wave, baseline, and this is T wave. P represent atrial depolarization. QRS is always and always ventricular activity, and P is a atrial depolarization. QRS is a ventricular depolarization, and this is ventricular repolarization, and there is again a U wave which is not seen. This is again atrial depolarization, so this is atrial repolarization. QRS is ventricular depolarization, and T is a ventricular repolarization. Basically, atrial ventricle contraction and relaxation. So that is depolarization, repolarization. Don't get confused. So S wave, PQRST, S, right? So S in a one lead, Q wave in a lead 3, and T wave in a lead 3. Is that clear to everyone? Yes or no? Tell me at least
Yes, sir.
yes or no.
Yes, sir.
S1, Q3,
Yes, sir.
T3. If you found S1, Q3, T3 until proved otherwise, how it looks like S1, Q3, T3, you need to do a lot of hard work. I am spoon feeding you. Everything is there in the screen, right? So S wave in lead 1, that is called S1. Q wave in lead 3, Q3. Inverted T wave in 3. So this is called S1Q333. So whenever you are suspecting in your emergency room, first your investigation is chest X-ray in general. You need to check oxygen saturation or arterial blood gas for this patient, right? And then you need to do one ECG. If you are suspecting ECG, PE, you need to look at the specific sinus tachycardia in ECG, and you need to look for the S1, Q3, T3. You need to know now what you are looking for in the ECG. Until and unless I'm suspecting any patient, chest pain patient come, my eye is always on ST elevation. I look only first of all, I what I see on any X-ray. Though I'm not a cardiologist, I'm a hematologist, but my patients like lung cancer or some pulmonary embolism, right? Cancer is the biggest predisposing factor for pulmonary embolism because cancer makes the blood hypercoagulable, and that is why they I have a lot of patients they also have a lung cancer but present with pulmonary embolism. They have stomach cancer, they present with PE in middle of the night with breathlessness. So what I see, somebody send my resident send me, sir, ECG, I look for S1 Q3 T3, I look for sinus tachycardia. If I'm suspecting MI, I look for ST elevation, I look for ST depression to label as a STEMI or non-STEMI. So these are the high yield point, you must know it. This is what the picture shows. Ventilation perfusion scan will come on that point, right? Now let me ask you more questions with PE. What is the best test to diagnose pulmonary embolism in pregnancy? Exam question.
Alarm Doppler.
9 months of pregnant female comes to you,
CTP.
right?
Doppler.
Or 34 weeks of pregnant lady presented with breathlessness, you are suspecting likely
Yes, sir.
pulmonary embolism. Which is the test of the choice in pregnant?
So
Yes.
so VP scanning, so
Duplex ultrasound.
Pulmonary angiography is not.
So there are three answer. So we'll discuss. No? There are three people answered me three questions. One is duplex ultrasound. Somebody told me ultrasound. Somebody told me VQ scan, right? Somebody
VP,
told
so
me
ventilation perfusion scanning.
So D-dimer.
when pulmonary angiogram, D dimer, fourth answer. Now again any answer?
Doppler.
So now who told D dimer?
So me.
Me means
Noha.
Noha, sorry. So now tell me, Dr. Noha, what information you will get it just for learning purpose. Huh? We are discussing. Don't take it away. So D dimer, if D dimer is high, what you conclude? Is it a
Non-specific.
what you expect of D dimer in P? You send D
So it's
dimer,
supposed to
okay.
be high.
D dimer is
It will be
1000,
high.
say for example, high. So
Yeah.
is it confirm the diagnosis? What my question is, based investigation of choice in 34 weeks of pregnant female in a suspected case of pulmonary embolism. Is that clear? My question is clear cut, yes or
Yes.
no?
Yes, sir.
Anybody has
Yes,
any
sir.
confusion?
Question's clear.
I
No,
am
no, no.
asking that 34 years female who is a pregnant 34 weeks, right, near to delivery, now come to the emergency room with breathlessness. You are suspecting pulmonary embolism, right? And they are asking which is the best test we confirm the diagnosis. Answer could be different. Initial test different. Base test different. I'm asking about the base test.
So I think VQ.
So I'll still
CT
go with
pulmonary.
angiogram. Yeah, I'll go for the tomography, computed tomography angiography.
CT. CT pulmonography.
CTPA.
Okay, so would you like to expose this patient for the radiation in
No,
CT
sir.
scan who is
No,
pregnant?
the computed tomographic angiography.
Yeah, so
I don't know. I still feel that.
okay, fine. So would you take a call and okay, now my question is changed.
So if there are
No,
abnormal features, then CTPA. If they're
So
found on for
we can
chest.
do ECG also. We can do like ultrasound of his leg as well. We can do duplex ultrasound. But
we can
sir,
do everything. We can do everything.
I still go with angiography.
My question is very specific. We can do everything. We can do ultrasound. We can do
Yes, sir.
except X-ray. We can do everything, right? Or radiation exposure. But what is the exact answer? Doing
So
everything
if,
is different.
so if there are abnormal features that are found on chest radiography, then we can go for CTPA in preference to
So are you
ventilation perfusion scanning.
sorry to ask you, are you
Yes.
still so much of aggressive to do the ECG in a pregnant woman? You don't want to avoid the risk of radiation to the fetus?
Yes, sir.
I'm just asking, this is practical question. Na? If tomorrow patient comes to your OPD, na, we all are practicing doctors, right? We are not just preparing, right? We are all practicing doctors. So if this patient, such patient's pregnant lady comes to your emergency, you are emergency physician on duty night, she comes to
Mhm.
you, want to order some test. So what test you will order?
VQ cancer, maybe.
So VP.
VQ, sir.
Yes, sir.
Okay, so let me ask you, why VQ scan, why not pulmonary angiogram? There must be some reason, na?
Invasive, non-invasive, sir.
Okay.
Risk
So
of
what is
radiation.
invasive, what is non-invasive?
So pulmonary angiogram, this is invasive. We would not want to go for it first.
Okay. So you want to go for first the non-invasive and then invasive.
Yes.
Okay, fair enough. Any other things? Any comment from audience? Because this all are question exam.
Do
Because
one
we are not
ECG.
thinking well. Sorry.
The pulmonary angiography. So
Pulmonary angiography is not feasible during pregnancy.
yes, sir. Yes, sir. It's not so VP scanning, I think, so it's the most appropriate. So CTP in case of abnormality.
Like ventilation perfusion scanning.
Yes.
Yes. So answer is VQ scan. Ventilation perfusion. It is
Yes.
VP, but people are VQ, so going VQ. But name is ventilation perfusion scan.
Perfusion scanning.
That's
Yes, sir.
yeah. So ventilation perfusion scan is the best, right? This scan is often preferring during the pregnancy because it exposes the breast tissue to the less radiation, number one, right? That is also important, right? So,
Yes,
so for the exam point of view, right? Answer is a VQ scan. So go and read it once again, right? We have many questions. Now, if this go my, I'll switch my clock little forward. How you gonna treat this patient now? That's the answer here. I mean, what is the treatment? So you suspected this patient as a pulmonary embolism, right? Because patient has a classical presentation, post-procedure, post-operatively breathlessness, tachycardia, right axis deviation. So now you are almost
Heparin,
sure that
sir.
it is heparin.
so
Patient
it's
has
intravenous heparin E.
Yeah, low molecular weight heparin. Like heparin.
Fine, fair enough. Another question. If I put these questions in such way, little twist in the question. Intravenous heparin. Now F option is low molecular weight heparin. Is there any change in the answer or same answer?
Low molecular
So
weight heparin.
intravenous.
Yes, we're gonna change to our answer to the F.
To
Okay,
the
fine,
yeah.
fair enough. Yes. So why you, Dr. Murad? What your last? Yes. So why you gonna? I mean, this both are heparin, na? Intravenous heparin, low molecular weight heparin. Both are heparin. So why you are? I mean, very much affected
Because
or
of sir,
passionate,
there is a
attracted
low
towards
risk of
LMN.
bleeding.
Sorry.
Low molecular heparin because of sir, low risk of bleeding, I guess.
Low risk of bleeding. Okay, fine. What else?
Sir, is DIC the reason?
Sorry, I'm not getting.
Is DIC the reason?
Why DIC? Why DIC in pulmonary embolism?
No, sir, the heparin. Not. I think I'm mixing something.
No problem. I'm just trying to understand your concept that, okay, fine, heparin. Now I twist the question. If the same question comes in your exam, you should know, na? So what will you post now? E or F? If E, why E? If F, why F? I want to know that. That's it. Anyone?
Maybe it's because lower risk factors.
Tell me now what are. So next question is, what are the lower risk factors compared with heparin? So let me draw the chart for you, doctor. This is
Because
unfractionated heparin or heparin basically, right?
sir,
Or
because
intravenous heparin.
low molecular weight heparin
Here
has
low molecular weight
less
heparin. Now tell
interaction
me,
with, has weaker, like less interaction with platelets and
which has a less interaction?
so
UFH,
LMH,
unfractionated
like
heparin.
low molecular weight heparin.
So that means in simpler way reduces the risk of thrombocytopenia.
Yeah, it has less
Okay.
interaction with platelets and bone
Okay,
formation.
so here a higher interaction with the platelet. So if you give heparin, conventional or the fancy name is unfractionated, this is low molecular. So unfractionated heparin, if you give, there are higher chances of thrombocytopenia. Here I can say lower chances of thrombocytopenia. This is what you mean to say, Dr. Niharika?
Yes, sir.
Okay, fine. So let's consider this point. What else?
It's a, I think cost as well, like low
Okay, fine.
molecular
Fair
weight
enough.
heparin
Cost.
is like
Okay, fine.
cheaper.
Okay, this is
We
cheaper.
have to monitor. We have to monitor after UFH
What?
use.
Yes.
Monitor
Okay,
PT.
so what? So how you monitor UFH? Which
With
test you monitor?
PTT.
PT, APTT, fibrinogen, PTT, right?
PTT.
Okay, and how you monitor LMWH efficacy?
Apparently nothing.
Yeah.
Nothing. Okay, nothing. Okay, fine. What else? Am I asking very bad questions to you guys?
Fast action.
Sorry?
Action is fast in
Which one
IV.
is fast?
IV, heparin, unfractionated.
This is fast. This is slow comparatively. That is what you mean to say?
Yes, sir.
So when this is fast, then why we are not selecting this fast one for this? Why people are answering LMWH?
And again, the thrombocytopenia.
Great. Wonderful. So you're on a second homework, right? Go and read head-to-head comparison and head-to-head difference between unfractionated heparin versus low molecular weight heparin. Don't take it lightly. This is all exam question. Right. Now tell me the treatment now. Okay, fine. So let's go. We will discuss that. Okay. So now treatment you want to start to this patient. What treatment you give? Okay, here I'll remove the LMWH now. So what's the treatment?
Unfractionated.
Why not
Thrombolize
warfarin?
the patient and then
Why not altiplase? What is altiplase? Why not altiplase? What is altiplase?
Patient is
So altiplase is given an acute myocardial infarction. It's
Okay.
anti-streptokinase.
Right. I understand, but it is also thrombolytic, na, basically. Altiplase, streptokinase, urokinase is all anti-thrombolytic agent, isn't it? Yes or no?
Yes.
So in pulmonary embolism, there is also you can give, na? So why
yes.
you don't want to give altiplase?
If it
Why
is
you don't want to give warfarin? You can give oral anticoagulant. Fine. So go and read complete chapter of pulmonary embolism. Excellent, excellently well given in the master the board. any step, either 2 or 3, whatever you have, you do it, right? So now this is the discussion of the questions. Diagnostic testing including P. Somebody told me, Noha told me the I guess D dimer, right?
Yeah.
Yes,
So
I.
D dimer basically it's like a, if you say for example you are suspecting pulmonary embolism, this is easier test to do, right? Because VQ scan, pulmonary angiogram, it takes time. So what you can in emergency, you can send the D dimer test, but it is not very specific test. Why? It is present in pulmonary embolism. It increases in the infection, it increases in the inflammation, it increases in the DIC, it increases in the another malignancy. If somebody has a esophageal cancer and they comes to your emergency, and if you find the D dimer, it can be present in. So there are long list of the differential diagnosis for D dimer, present, which is present in this, right? So it's not a good sensitive or specific. Sensitivity specific. Okay, fine. Pulmonary embolism you are suspecting, and it is a, say for example, 10,000. Your suspicious is high that it could be D dimer. It could be pulmonary embolism. But what is the importance of D dimer is, if it is negative, say for example, it likely rule out that this is not a P. Likely rule out that it is not a P. Is that clear, Dr. Noah? Yes or no?
Yes, sir.
If it is positive, there is a long list of the differential diagnosis of D dimer. You go and read in which condition the D dimer positive. I mentioned almost all the condition where you get a high D dimer test, right?
Yes, sir.
And right, but if it is a negative in suspected pulmonary embolism, and if D dimer is not very high or normal or low, almost there is a gone that there is a no pulmonary embolism. So you can exclude, right, that okay, there is a no pulse. So when you want to confirm whether P is there or P is not there, if P is there, D dimer you did, D dimer is normal, most likely there is no P. But if it is a high, it is not a sensitive. On D dimer, you cannot start the treatment on D dimer. You cannot start the treatment. You need some kind of confirmation by initial chest X-ray or VQ scan or pulmonary angiogram, blah blah. Right? Then, right? But one more thing. When patient you are suspecting P and patient has a deep vein thrombosis, patient has a confirmed deep vein thrombosis, direct treatment is heparin. You don't need to confirm by any test. In a case of DVT with symptoms, until proved otherwise, you start the heparin without confirmation. This is practical as well as the book recommendation. So diagnostic test of P, no single test, right? But best initial is what? Chest X-ray, obviously breathlessness patient, EKG and ABG, I told you. So if the question is asked in the exam, what is the initial test? Then chest X-ray, EKG, and ABG, arterial blood gas, right? Second is, after this have been done, best next step is a CT angiogram, right? And chest X-ray is usually not, right? So best is this. Just remember the high stem questions, right? Best next is angiogram, non-pregnant, pregnant VQ scan again, right? Is that clear, doctor? Yes or no?
Yes, sir.
Yes.
EKG, usually sinus tachycardia. So three questions we've seen: sinus tachycardia and EKG. Most common abnormality, non-specific, is STT wave changes. That is not given the right answer by someone, right? But I noted down. So most commonest or usually seen most common abnormality, right, is usually is a sinus tachycardia. Most common abnormality is a non-specific STT wave changes. Right, less common is right axis deviation, but it is there, which can be seen on ECG, as well as right ventricular hypertrophy with RBBB. So these things can be seen in the ECG. So very clear, don't get confused. So it is not a, Dr. Benis, it is not a coronary angio thrombosis, right? Coronary artery thrombosis, right?
Okay,
Because
sir.
you cannot see in coronary artery thrombosis this sinus tachycardia, right ventricular hypertrophy, right heart or right axis deviation. Is that clear? Yes or no?
Yes, sir. Yes, sir.
Yes.
Wonderful. So now concept is clear. And CT angiogram has excellent specific, excellent, the highest, more than 95% specificity and sensitivity, right? So if you can not get the idea by any means, right, then you do the CT pulmonary angiogram, right? That is a confirmatory test, right? So when you pick up something in earlier things, right, by ECG, by X-ray, or by VQ, you find that okay, fine, this is embolism, no need to go for CT angiogram. But X-ray is normal, D dimer is inconclusive or equivocal, VQ scan is not available, right? Then you are confused what to do, right? So in that case, you can go for CT angiogram as the most sensitive and specific test, right? See, now I told you, CT pulmonary or VQ scan is not needed. This is I taken it from book, word to word from book. I taken it today morning, right? So not needed, right? So CT or VQ is not performed to confirm P means pulmonary embolism if there is a clot in the leg, because they would not change the treatment. Patient is still need anticoagulation for 6 months. So when there is a deep vein thrombosis, breathlessness, risk factor, sinus tachycardia, S1Q3T3, you don't need CT pulmonary, you don't VQ, irrespective whether it is positive or negative. You need to treat DVT to prevent PE, so you need to give anticoagulation. That's it. And treatment is also effective along with the low molecular weight heparin, that is enoxaparin, right? So NOAC. Can anyone know what is the NOAC? NOAC. What is the full form of NOAC? Newer oral, direct oral
Anticoagulant.
anticoagulant drug. So newer means there must be some older, no? There must be some older. So which one is older? Older is a warfarin.
Yes, sir.
Means years and years. It's not given in the book. It's a old oral anticoagulant. But just for your understanding, when somebody say,
Mm.
right, there are two things. No? Newer means we are thinking, no, what's the older then? Right? So warfarin is for years and years, but newer oral or neural direct oral anticoagulant drug or LMWH. This is injection. This is a sub-Q
Yes.
injection, subcutaneous injection. This is newer oral. Oral means by mouth per oral. So this is a tablet. So now tablet is as effective. So NOAC or LMWH heparin. This is book line to line from the books. Followed by warfarin. NOAC or oral agents includes rivaroxaban, apixaban, endoxaban, and dabigatran. Right. So they are NOAC are as effective as LMWH. Clear cut line. NOAC. Newer oral anticoagulant drugs are as effective as enoxaparin, that is low molecular weight heparin, or you must have heard in India the brand is Clixan. Clixan. It's a very famous brand. Clixan. So we give in ICU every day, right? And warfarin for P and DVT. Is that clear to everyone? Yes or no?
Yes,
Yes
sir.
or no?
Yes, sir.
Yes, sir.
So say for example, patient don't want to take low molecular weight heparin. Now we have options, NOAC. You give a drug, rivaroxaban, dabigatran, apixaban. This all oral drug, very easy. And biggest advantage of this versus low molecular weight heparin versus DOAC. Earlier the name was DOAC, for your knowledge,
Yes,
direct
sir.
oral
Direct oral.
anticoagulant. Now NOAC, newer. Right? So this is direct. So this is what the difference between this thing. This is a sub-Q injection. This is per oral. This is one different, right? This is effective. This is also equally effective. So it's a good thing, right? This no need monitoring. Here, no need monitoring. Here, no medical or no paramedical staff required to administer. This is more easier to administer. Na? Oral drug. Anybody can take at home. Otherwise, they need to call some nurse or something. Everybody is not comfortable taking injection by their own subcutaneously, right? Can anyone tell me what is the antidote of low molecular weight heparin, and what is the antidote of oral anticoagulant drug?
Protamine sulfate.
Work. If you have a low molecular weight heparin, is there any antidote of
Prota-
LMDH? Is there any antidote of heparin?
The
Vitamin K.
protamine sulfate.
Heparin antidote. Exam question.
Protamine, I think.
Yes, not you think it is. You are right, sir. Protamine. So heparin, protamine. Low molecular weight heparin, again protamine or any other drug.
Vitamin K.
Vitamin K is for warfarin.
Vitamin K is for warfarin, not for heparin or low molecular weight. So homework, third and fourth homework. Find out what is a low molecular weight heparin antidote. I want you to open the book. That is, I am not giving all the answer. And what is the antidote of DOAC or NOAC? Is that clear?
Yes, sir.
Hemodynamically stable patient can be treated with NOAC. Means hemodynamically unstable patient cannot be treated. Is that clear or not?
Yes, sir.
Hemodynamically stable patient can be treated with NOAC like this pendoxaparin alternative to heparin. It is safe to use with heparin
So
induced, right?
protamine,
It's safe.
so protamine sulfate
Yes.
is not the antidote of low molecular weight heparin.
No, not. That is your homework. Yes or no? Would you
So
like to
low
do the homework or no?
Sir, I would like to do. I knew that. I would like to do it.
Yeah. Post it in the group so everybody will learn. Right? Is that clear? Yes or no?
Yes, sir.
Treatment is suspected pulmonary embolism with heparin, which is then followed by warfarin. Unfractionated heparin is given intravenously and low molecular weight heparin given subcutaneously. Right? That's it. So this is what the thing is. All tactics, all about various questions about P, what ECG changes, X-ray, pulmonary angiogram, treatment, DOAC, LMWH, this, that, blah, blah. Very interesting sentence last. When a history and the initial labs are suggestive of P, that is pulmonary embolism, it is far more important to start the therapy with LMWH or enoxaparin or DOAC or NOAC. See, depends on your center. Na? If your center does not available low molecular, say for example, small setup, that does not mean you don't give the uh, heparin intravenous. You give heparin intravenous. Why we are discussing this? We need to know all the possible options of the treatment of pulmonary embolism. If you are sitting in a best of the best hospital like me, the corporate hospital, right? Everything is available. In that case, I probably start with low molecular weight heparin, right? And when patient discharge the home, I will switch to the NOAC. That's it. Simple. That's it. Is that clear? Right? If my hospital doesn't have, right? If my hospital doesn't have this the any oral anticoagulant or newer drug, I'll start. Or if I don't have low molecular, I'll start with unfractionated heparin. That's it. I monitor. Basically, you need to start treatment as soon as possible as per the resources available in your hospital. So all are okay. See this line. This line is not I written this line. This is from book I taken. When the history and the initial labs are suggestive of P, it is far more important to start the therapy with LMWH or enoxaparin or NOAC, right? Than to wait for the result to confirm testing, blah blah. So if you are suspecting, you start the treatment, whatever available with you. When is the embolectomy is the answer? When is the embolectomy is the answer, Dr. Bina? Dr. Benis, what is the answer? Anyone? Anyone would like to try? I am saying that there is a pulmonary embolism. Now I want to do pulmonary embolectomy. I want to do. What are the indication? When I
So,
supposed to do? This is exam question.
so
Yes, tell.
when the embolism is very large,
Large, 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter. Answer.
uh,
Sorry to
so
ask
I
you.
don't know.
This is
So like
practical,
if
isn't it? Large,
it's a
there must
massive,
be some definition. Definition of large means something is there, na?
So if there's intracranial hemorrhage and after that there is massive PE, then we
Sorry,
can go
can
for
you
it.
can you can you make me understand what is a intracranial hemorrhage comes from where now? I mean,
So intracranial hemorrhage. So intracranial
intracranial.
hemorrhage is it's a bleeding. It's due to brain damage. It's mainly due to hypertension or
No, no. So
It
how
it
you
occurs in
aneurysm.
those
correlating? No,
it
no. I'm
occurs in
just
those
trying to
who went
understand
for
how
craniotomy.
you correlate how you correlate this intracranial hemorrhage and pulmonary embolism. I mean, just trying to understand.
So pulmonary embolectomy, sir. The indication is if there is a massive PE. So like then
Okay,
after,
fine,
for
fair enough. So
example,
massive PE.
yes, sir.
So massive PE, not the intracranial hemorrhage, because if there is an intracranial
Yes, sir.
hemorrhage and you give heparin, it will worsen the hemorrhage, isn't it?
Yes, sir.
Yes or no?
Yes, sir. Yes, sir.
Heparin will
And
make
if
the blood.
somebody has contraindication to thrombolysis, then we can perform pulmonary embolectomy or
Okay,
failed catheter assisted embolectomy.
okay.
Shock
So
is also
okay, so embolectomy with a catheter is done only if there is a persistent hypotension,
okay, sir.
hypoxia persistent, and thrombolytics, as you rightly said, contraindicated or ineffective. You had given the thrombolytic, right? Altiplase you had given, but it doesn't work. Patient has same thing. Patient has no improvement. Patient has hypoxia. Patient has tachycardia. Still S1Q3 T3 after 15 minutes. Blah blah.
Yes, sir.
Right? So in that case, embolectomy. So when patient is shocked, basically persistent hypotension is basically in shock, right?
Yes,
Where
sir.
you need to something do urgently, very urgently. Otherwise,
Yes,
patient will die. Na?
the
Yes, sir.
unstable one.
Hypotension is like urgency. Na? So patient
Hemodynamically
in
unstable
pulmonary,
patient.
so pulmonary embolism with unstable patient or in shock, right? Immediately
Yes.
do embolectomy. You remove the embolus. Job is done. That's it. Because pulmonary embolism, you want to remove the embolism. Who will? It's like a. It's like, say for example, important to discuss, right? Acute MI. If you have PCI, pulmonary
Mm.
primary coronary intervention, right? Just hold on for 1 second.
Percutaneous.
Yeah, so acute myocardial infarction, the ideally we can do in this patient, right, is a PCI, right? Percutaneous coronary intervention, because this is the fastest thing which will save the patient. If you do not have PCI, right, then you can go for the thrombolytic. Right? This is again
Okay.
exam questions. Same way
Mm.
in pulmonary embolism, right? If patient is in shock, the fastest thing is to do the embolectomy. Is that clear? Yes or
Hemodynamics.
no?
Yes, sir.
Yeah, so this is the things. Now switch to the next question. So everyone I want everyone to read this. Extremely high yield, pulmonary embolism, acute coronary syndrome, right? What we discussed, this all scleroderma and earlier. This is the spot diagnosis question. So there is no option, nothing. They won't give you in exam much this. This is the baby. What is the history? What is the diagnosis? Look at the picture. What is the treatment? Honey colored scab on the face
Impetigo.
of a school
Impetigo.
aged child. Honey colored scab on the face of a school aged child. That's it. This is what the picture is. So what's the diagnosis? What's the treatment? I need a two things. I need a diagnosis. I need a treatment. Because exam they can ask you treatment as well.
So it's Impetigo, and the best treatment is topical antibiotics like
Okay,
mucosin antibiotic ointment.
Banish, right?
Yes, sir.
Wonderful. Let's wait for one or two answer. Huh? We'll discuss. Dr. Kanika, your comment. If you have this child in your OPD tomorrow morning, any comment, Dr. Kanika? Fine. She must be on duty. Yes, anyone, Doctor? Samir Suleiman, Nasira, Yogpriya. We are
It's Impetigo,
Impetigo.
and
Okay.
and then treatment be local application.
What is the treatment?
Topical antibiotics and alone or
Yes.
with conjunction with systemic antibiotic.
Okay. Okay. So now let me ask you, any comment, Dr. Noha? What's the treatment? Dr. Ravi, Dr. Shafi, any comment on this treatment? Any specific particular
Topical
drug?
antibiotics,
Topical antibiotics.
and if it is
Yeah.
the lesion is
Can you name
widespread,
one
then
name of the topical antibiotic? Any
Mupirocin,
name?
mupirocin,
mupirocin.
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 Okay. Any other comment?
If it is more widespread, we need systemic antibiotics.
So topical antiseptic like hydrogen peroxide or pivoine iodine can also be applied if it's uncomplicated, non-bullous impetigo. And if there are 3 or 4 or 5 lesions or bullous impetigo, then we can also give oral antibiotics.
Sibi, mana sih? Enda bibi, cakir mana? Lebih mana? Sambri, enda kecil, enda sambri.
I can't hear you, sir.
Oh, sorry. So this is Impetigo. I was wondering to get the idea how you differentiate impetigo, erysipelas, cellulitis, right? Carbuncle, furuncle, boils, right? So you need to know. You need to go and read it once again. I got fortunately excellent picture while reviewing my lectures for you before presentation. I got excellent picture. Let me share this picture with you. Anatomical site of the involvement of skin or soft tissue infection. So first is there are layers of skin is what? Epidermis, dermis, hypodermis. Epidermis is skin, right? Stratum cornuum and stratum germinatum. This is epidermis. Hair follicle is growing from this, right? Crusted vesicles, right? That is impetigo. So impetigo is the most superficial, right? Predominant site of involvement, right? Predominant site of involvement. So this is epidermis in impetigo. This erysipelas is a little more deeper. It goes to epidermis and also dermis. If you can see skin abscess, it is epidermis and dermis, right? And cellulitis, can you see this? Epidermis plus whole the dermis, right? And fasciitis even more deeper, right? And in hypodermis, what things comes in hypodermis? Subcutaneous fat, deep fascia, lymphatic, lymphangitis, muscle bone. It is in hypodermis, right? So these are the various levels of involvement of the skin, which I think it is most self-explanatory, excellent picture slides. I got it from another Western world book. I don't know the name of the book, but I was reading my lecture. I got this book, so I thought let me share with you. I'll share with you. So this is basically the impetigo, right? And correct answer is impetigo. Impetigo is a skin infections caused by bacteria, either group Streptococcus, Staphylococcus aureus, or both. And group A Streptococcus bacteria causing impetigo, and they are contagious, right? So this is exam question, contagious, right? This group A Streptococci and symptoms, as you told, it is usually takes 10 days for sores to appear after someone is exposed to group a streptococcus bacteria. Symptoms include red itchy sores, break, blah blah, right? And this is the appearance, and it can seen in the things. Crusty yellow or honeycomb scab forms over the sore, and that heals without the scar, right? So again, as I told you, the homework I am giving you: folliculitis diagnosis and treatment, furuncle diagnosis and treatment, carbuncle diagnosis and treatment, boils diagnosis and treatment, cellulitis diagnosis and treatment. That's it. So this is what you need to know, right? So they may ask you anything in exam. So impetigo is a superficial skin infection caused by staphylococcus or streptococcus. Impetigo is a more common in children, is highly contagious, and can lead to a formation of bullous lesion, right? So that's it. So this is what the thing is. Let's jump to the next question. ABG. It will check your knowledge of ABG. Probably will stop then. Uh, so which of the following is most likely to be found in aspirin overdose? You have all the four options: A, B, C, D. You read you read all four options: pH, PCO2, PO2, HCO3, and give the answer. And main why. I am interested in why. Why A, why B, why C, why D. Somebody who is giving me the answer, you have to explain me why. Now my sound is not there, yes or no? Somebody is posting no sound. Am I audible or no?
Yes, sir, audible.
Audible. Thank you very much. Yes, now. So tell me, what is this? Anyone wants to try these questions?
The respiratory metabolic
Alkalosis.
acidosis and respiratory alkalosis.
Respiratory alkalosis. Yeah.
1 minute, 1 minute. So first who explained it, so I want to discuss. Your name, doctor? Your name, doctor?
So this is Noha here.
Yeah. So now tell me, what happens in a aspirin overdose? Number one.
So there will be lactic acidosis.
Lactic acidosis. Okay. So what? How the patient present with aspirin overdose? So if some patient has taken very high amount of aspirin overdose, how do they present? What is the clinical symptoms? How they present into the emergency room? If they ask you, right,
RR
by
will
the
be high. Respiratory rate would be high.
sorry, Noah.
So RR will be high in vitals.
Okay, so tachypnea basically. RR is
Yes,
respiratory rate. That is what you mean to say?
yes, sir.
Okay, fine. So respiratory rate is high. What? Only respiratory high? That is the only thing, or any other things?
No, no, no.
Anyone? Niharika?
So fever, hyperventilations, seizures.
Fever, then hyperventilation, then
And
seizure. Okay.
So diaphoresis can
tinnitus.
be there.
What can be there?
Diaphoresis.
Diaphoresis. What is diaphoresis?
So diaphoresis is like this excessive sweating in a patient. It's caused by hyperhidrosis,
Sorry.
abnormal sweating.
So what is the simple definition of diaphoresis?
So excessive sweating in a patient.
Excessive sweating. Okay, fine. Okay, so what happens? What metabolic changes happen in aspirin overdose?
Respiratory alkalosis and metabolic
Okay,
acidosis.
wonderful. So somebody explained that respiratory acidosis.
Respiratory alkalosis.
Okay,
Alkalosis and
respiratory alkalosis compensatory leads to metabolic acidosis, right? If I'm
yeah.
not wrong.
Yes, sir.
Fine. So now you find out what your respiratory alkalosis or leads to metabolic acidosis fits to this ABG. Which A, B, C, D? This is
So
we
it's
reach to the conclusion that aspirin we knows it causes the respiratory alkalosis, right? So this is a primary things and compensatory is a metabolic acidosis. So respiratory alkalosis is from what favors the respiratory alkalosis now. You look at the things. Now you need to know what is the pH. pH is high is acidosis or pH low is alkalosis. You need to know acidosis, alkalosis range. What is
pH
the
is high
pH?
in alkalosis.
Sorry.
pH is high in alkalosis and low in acidosis.
Wonderful. So pH is high in acidosis, low in acidosis and high in
And high in
alkalosis, right?
alkalosis. Yes.
I'm muting all because somebody is doing background talk. You can unmute. Niharika, sorry. So let me first go to the basic. This is the basic. I am the man with looking for easiest technique to remember. So I'm quite good. I'm not praising myself, but I have that skill. So this is the things I can tell you. This is a speedometer. You know your this is your car, and this is a speedometer. And this speedometer 7.35 to 7.45. This is a normal range. Is that clear? Yes or no?
Yes, sir.
If pH, this is called pH. If it is less, acidosis. If it is high, alkalosis. Right? So you need to remember first normal pH. What is the normal pH? 7.35 to 7.45. Now remove the 7 here. 35 and 45 is a carbon dioxide. Is that clear? Now easy? Now easy, little easy. Yes or no, Niharika?
Yes,
Right?
sir.
Yes.
So 35, 45, 45. Remember, right? So you can easily remember. But this is 7.35 to 7.45. Now you need to know 5 parameters. PCO2, right? Arterial, because this is ABG. ABG is a arterial blood gas. VBG is venous blood gas. We are talking about arterial blood gas. So when you take from radial artery or femoral artery, we do in all patients of breathlessness, right? Or patients neurologically deteriorated, right? Or poisoning patient, we do ABG generally, routinely, right? Irrespective. So pH we need to know 7.35 to 45. PCO2 is 35 to 45. Now, like arterial carbon dioxide, oxygen, 75 to 100%. HCO3 bicarb, 22 to 29 or 26. And SPO2, we call it as SPO2, right? Arterial oxygen saturation, we see, right? From pulse oximeter. You use it in your OPD or IPD, yes or no? Pulse oximeter, right? Or oxygen saturation. So oxygen saturation should be more than 90. This is the normal range. So first of all, you need to know the normal range, right? It's just one time job to little remember, but I make it little easy for you right now, right? So 7.35 to 45. So see, I'm trying to make you understand in an easier way. If it is less acidosis, acidosis. If it is high, alkalosis. This is one basic thing. Same way, if this is PO2 is low, it is alkalosis, and CO2 is high, is acidosis. So if you have more carbon dioxide in your body, it is acidosis. If you have less carbon dioxide in your arterial blood gas, it is alkalosis. Everything is compensatory, right? And same here, the reverse. Here the CO2, PCO2 is high acidosis. Here PCO, here soda bicarbo high is alkalosis. No need to mug up. Is that clear? So it is opposite to this. CO2 high, acidosis. HCO3 high is alkalosis. Here PCO2 is low, means alkalosis. And here this is low, is acidosis. Is that clear? At least tell me yes or no. Tell me yes, yes or no.
Yes, sir.
Yes, sir.
Right? So this is what the basic is. So first, until and unless you understood this concept, you never ever be right in acid based questions in your exam. So first we need to know the normal value. If it is less, pH. So any now gets the algorithm. Now we know this now. We know this chart now, right? Now let's apply to this chart. Now apply that basic knowledge of our chart in this scenario. So what we know in aspirin overdose, right? Aspirin overdose, as doctor rightly said, there are first of thing is a respiratory alkalosis. Is that clear? Yes or no?
Yes, sir.
So now what our first job, any ABG question, first decide acidosis or alkalosis. Is that clear or not? Yes or no?
Yes, sir.
Then you decide metabolic or respiratory. But first job is to decide acidosis or alkalosis. So here alkalosis. What is the alkalosis? Normal is 7.35 to 7.45 is the pH. How do we get to know that alkalosis? So if pH is more than 7.45, it is alkalosis. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
So now
Yes.
look at the scenario where the pH is 7.45 or up. So should I remove this book?
A and C.
Should I remove this because pH is 7.25? That is acidosis. We don't need it, right? Yes or no? Tell me yes or no.
Yes, sir. Yes,
Yes,
sir.
Yes.
So I am
Yes.
removing this because this is acidosis. 7.35 again it is acidosis. So I'm removing this as well because we are talking about alkalosis. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So now we are talking about the respiratory alkalosis. So in respiratory alkalosis, CO2 is high in alkalosis or low in alkalosis? CO2, PCO2. It is normally 35 to
Low.
45,
Low.
right? PCO2 low. So low, so PCO2 here 22 and PCO2 here 50, right? Normal range is 35 to 45. So which one is low? 22 or 50?
22.
22.
So A is gone. So answer is C. Yes or no?
Yes.
Yes,
Another
sir.
question. It leads to metabolic acidosis. So now look at the HCO3. Normal is 22 to 26. Normal is 22 to 26. High 22 to 26. High is what and low is what?
Low is acidosis, high is alkalosis.
Excellent. So low is acidosis, reverse than CO2. Don't get confused. So low is metabolic acidosis. So here see the HCO3 is also low. Is that clear? Yes or no? Is that clear? Yes or no?
Yes, sir.
Yes.
So this is how you have to understand. I have more tips for you as well. So another chart I created for you. Another. I'm trying to make your job easy, right? So this is the chart for you. Again, bigger chart. So what's your first step in diagnosing any acidosis or alkalosis question, right? Is number one, first decide acidosis or alkalosis. So respiratory alkalosis. So first we see the pH, right? Then we see the CO2, right? So we primarily identified our job that respiratory alkalosis, and that leads to metabolic acidosis, means HCO3 was low. So all these three things, now it's clear for you or not? Now if you can, now I think it is a little better for you to understand, right? Yes or
Yes,
no?
sir. Yes, sir.
Right.
Yes, sir.
Here, here, first decide the acidosis or alkalosis, and after deciding the acidosis and alkalosis, second step is respiratory or metabolic. That's it. Job is done. That's it. Job is done. Right. So less than 7.35, it is acidosis. More than 7.45, it is alkalosis. In acidosis, there are two community: respiratory acidosis or metabolic acidosis. So when CO2 is high, CO2 is high more than 45, normal is 35 to 45, right? More than CO2 more than 45 is acidosis respiratory. And if this is low, it is metabolic acidosis. Less than 20, our is 18 or 16. That's it. Same way applies to here. So that's all from my side for ABG. It's not that complex the way you think, but you need to just little bit know the basic how you gonna I mean crack this question, right? So again you go and read it, try to solve couple of questions. We have a lot of questions on our website, acid base and what every question is from a website for whatever the mock test, everything is there, but it's in a different department. I club up all the things together, right? So I'll stop it here with your kind permission. So before I stop, I usually take some quick feedbacks from the audience. So those especially joining my class first time, Dr. Niharika, probably Dr. Binish. So you can give some feedback how you enjoyed the class and what's the learning for you in today's class.
Sir, I think
Sir,
everything is good only. I don't think so. Any feedback is needed. Like it's good only.
Yes, sir.
Okay,
So it was a nice session.
wonderful,
Thank
wonderful,
you, sir.
Sorry, doctor, I
wonderful.
have a question for you. So what's the differences between when we asked about on the end of the question, when we ask about what's the next most appropriate investigation or what's the best appropriate investigation? So what's the
So,
difference?
yeah, not much difference, honestly speaking, sir. Whenever you are answering any questions, you need to look at the proper word, what they mention. Initial is different from the best investigation, right? And most appropriate is close to the most highly sensitive and specific. You understand? Most specific, right? So they will not confuse you definitely, but I'm just giving you more detail insight how they ask in the exam. So your skill will
Okay.
develop more. That is what I'm doing. So you need to concentrate on the questions, honestly speaking, what they exactly ask. What best next step? Best means what is the best modality available? It is the best test or most appropriate test or most sensitive and specific test. That is how we have to take it into the exam.
Okay, thank you. So
Right.
whenever we ask about what is the next best step, so it means that was the initial next step. Am I right?
Usually, I mean, they will not confuse you as I told you, number one, right? So, base test initial is different from the base test. See, always, every time. I mean, whatever renal stone, base test X-ray. I mean, initial test X-ray KUB, base test CT scan, right?
Mhm.
Like that only. So you need to see the clinical dignity, what they wants to ask, right? And probably they will not confuse by giving the two option in a one question, right? Exam is very clear cut. You understand? So they won't confuse you. You give you the two options, so you get confused. What is the next step, or what is the best next initial step? What is the next best test, right? So when the word comes best or most appropriate, try to use the best investigation from the choice. That's it.
Okay, awesome. Thank you very much.
Because after initial you want to confirm it, right? So when they are specifically as what is the best next step, then you select the next from based from the all the things, right? That's it. Thanks. Anyone wants to make any comment, would be happy. Anyone about the class or something new learning? No comment?
Sir, after a
Yes.
long time, I joined a mock class
Please,
like
please,
this.
I mean
A
your doc.
really long time. I'm Dr. Noha,
Yeah, no,
and
please go ahead.
yeah, so it was actually like refreshing, and it was like actually coming back to the MBPS classes. So yeah, it was like a very good.
Yeah, great, wonderful. Yeah, yeah. I prepare a lot before I present. Wonderful. Thank you very much all for your kind presence. So I'll upload this on our YouTube channel as I told you at the initiation of class. So stay tuned. You can post your feedback in the group as well. Anyway, thank you very much.
Thank you,
So
sir.
see
Thank you
you
very
in the
much.
next class. Thank you very much all for your kind presence and enjoy your Sunday. Thank you.
Thank you.
Thank you,
Yes,
sir.
sir.
Thank you.
Thank you.
Take care. Thank you.